में जा रहा सुनो आगे चलो ठीक. So for learning objectives, today we will learn about the common causes of the back pain, and we will classify backache, and we will learn how to clinically assess and do the clinical assessment of a patient who comes to us with backache and in our clinic, and what is the diagnostic approach to deal the patient with backache, and how we will treat these patients having back problems. मैं अपना मास्क उतार रहा हूँ, यहाँ पे कोई भी नहीं है. So I think you will learn the basic concept of the back problems in today's lectures, and I will try to teach you the main problems that causing backaches. We will backache or back pain is a very diverse topic, so we'll try to sort it out in 1 hour duration. So by definition, pain and the muscle tension or stiffness or spasm localized below the costal margins, below the rib cage or costal margins, and above the gluteal fold, with or without leg pain. This is called backache, back problem, or a lower back pain, and it is further defined by International Association of Study of Pain into 3 components: either a lumbar spinal pain, or sacral spinal pain, or a lumbosacral pain. So the gluteal pain or a loin pain is not considered in lower backache. So we have to differentiate these things. So what is actually the backache? The low back pain confined to the lumbar spinal region, sacral spinal region, and lumbosacral region is considered to be low backache. So the epidemiology, the second most to the common cold frequency in adult ailments. Fifth most common reason for a doctor to visit in the OPD, and the source of the lower back pain is mostly mechanical in 90% of cases and has a good prognosis. And every individual in his lifetime, especially more than 80% chances that he will have an episode of a backache. The most common causes of disability in patients in less than 45 years old. Now comes to the classification. How we will classify backache? Generally, there are many classifications, but in general terms, it is classified into 3 types: acute, subacute, and a chronic. Acute is less than 1 month, subacute is 1 to 3 months, and chronic is more than 3 months. So if a person came to us with a history of back pain more than 3 months, we consider it as a chronic, not an acute. So that's the duration is very important. So the other we can classify into a mechanical according to the cause, like a mechanical one or a non-mechanical one. The most commonly, as I discussed earlier, is the most common cause of low back pain is mechanical. More than 80% of the low back pain is from mechanical causes, like prolapsed disc, osteoarthritis of the spine, spinal canal stenosis, spondylolisthesis, and the compression fractures of vertebrae. Sometimes ligaments and muscles spasm. These are all called mechanical causes. The non-mechanical, which is not very common, are tumors, primary tumor or secondary tumor of the spine arising from the spine, or mets, infection of the spine, including osteomyelitis, or a chronic infection like tuberculosis, or a discitis, or infection from the discs, or inflammatory arthritis like ankylosing spondylitis or rheumatoid arthritis. Though the rheumatoid arthritis not commonly involves the lower spine, it involves more of the cervical spine. You must remember that the rheumatoid involves more of the cervical spine rather than the lower spine. So there are some other differentials as well. When we talk about the back kick, for example, visceral disease. For example, a person with abdominal aortic aneurysm can present with backache, or patient with a renal stone can present with backache. A patient with UTI, urinary tract infection, can present with backache, or a patient with the pancreatitis can present with backache. A patient with prostatitis or pelvic inflammatory diseases, especially in females, can present with backache. So these are the differentials we have to consider, and we do differentiate according to the history and clinical examination and the relevant investigation to rule out these differentials, either mechanical with the non-mechanical or visceral disease. So we can classify also according to a complicated or uncomplicated one. So what are the complicated? The complicated are the red flag conditions. I will talk to you later. And uncomplicated, non-specific diagnosis of infusions. So the comes to the history of the patient. हम क्या देखेंगे पेशेंट में जब हम पेशेंट आएगा हमारे पास ओपीडी के अंदर? What we will do? What we will ask? How will we proceed? What are the different questions we will ask in OPD? These are some biodata and general questions and the relevant questions. History remains, orthopedic history remains the same. History of presenting complaint and past history, past medical history, past surgical history, and the socioeconomic history and all that. We will not talk about detailed things. We will just focus upon the relevant history of the backache. So how the age is important. As I told you that any person can have backache, but backache in different ages have different causes. For example, if a patient with backache of age greater than 70 years, we must consider osteoporosis as a cause, or some malignancy, or a metastatic disease, or a lymphoma as a cause. But we do not consider it in young age. In young age patient, less than 45 years old, we consider disc prolapse as a cause, or as a muscle strain, or infection, discitis, and the cause. So the age is very important. It leads to the diagnosis, differential diagnosis. The other one is the weight of the patient. If the patient is overweight, thin, lean, because as the weight of the patient is increased, there are more chances of the osteoarthritis of the spine or a disc prolapse increased. It's directly proportional to the patient. Then comes to the occupation of the patient. We must ask about the occupation of the patient. So, for example, if a patient in the sports having heavyweight laborer or a gym, so doing heavyweight exercises, so there are more chances of having a backache or back problem with acute onset, sometimes chronic onset as well. So the occupation leads, very important, and it leads to the diagnosis and help us making the diagnosis. So we must ask patient's age, his weight, his occupation. Then we will comes to the time of onset. As I told you earlier, that time will be very important, as we have to classify into acute, subacute, and chronic. So time of onset is very important. How much time is, so that we can identify the causes accordingly. Then the duration. How long? How long? 1 month, 2 months, 3 months, 4 months. This is on and off. It's first episode or a second episode or third episode. It's continuous in nature. So the duration is also very important. Sometimes backache have a problem with the during night. Sometimes backache have a problem during early morning. So we have to consider it. For example, in patient with ankylosing spondylitis, morning stiffness, present with morning stiffness and backache, most commonly in the midnight or early morning. While patient with arthritis will go when it starts working. So the time is important. Now comes that to we will ask about the how we will localize the pain. You have to ask the patient that you go and put your finger where you are feeling the pain exactly. You can point it out where you actually feel the pain. So you have to localize. Patient will tell, this is the point where I'm in pain, and this is the path it goes. Either goes up or down, or just behind the buttocks and the posterior aspect of the thigh or the anterior aspect of the thigh. So we have to make sure. So how a patient define or localize the pain. And then comes how the pain radiates. Because sometimes pain radiates, sometimes pain does not radiate. And we have to ask it. If we don't ask it, patient will not tell us. Sometimes, for example, in cases of osteoarthritis of the spine, patient does not localize the pain or radiate the pain. In cases of just only he will get a lower back pain in the middle of the back, and it will not radiate anywhere. In cases of bursitis, it might not radiate anywhere. But in cases of prolapsed intervertebral discs or radiculopathy, having a radiculopathy, it will radiate. And where it radiates, it shows actually the dermatome where it goes. So we will have to ask these questions of the patients. Then comes the history of trauma. Either it is due to trauma, if there is a past history, or there is a present history of accidents or a fall, that comes with pain or not. It's very important because we have to rule out the fracture or associated fracture. Backache as a cause of fracture. That as I told you earlier, that sometimes patient puts a heavy weight. So it is also a cause. In our daily routine work, we will see that we are engaging with backache with the water cans. We will put up on and place it over the dispenser. So this is a common cause these days for a backache in young patients in our country. So the other questions we will ask, that either a numbness in the foot, we feel numbed foot or not. Sometimes if it is numbness, so it shows that the pain is radiating and it is compressing the nerves. And the movement of the foot, sometimes the pain is so severe that it comes with the numbness and loss of motion. loss of muscle power. It means that there is an emergency and it needs to be addressed. Emergency, need a surgery or something because it is compressing the nerve. So we'll have to ask the patient that either you are losing power of the limb or not. Either you have a urine control or not. You have a stool control or not. So you have to ask the patient these questions. These are the relevant questions related to backache. Then comes the urinary complaint. Either you have asked patient that you are having a burning maturation, because sometimes backache present with UTI. Then comes the fever. Yeah, is the backache or a back pain associated with fever or not? Because if it is leads to some sort of infection. Might be osteomyelitis, might be a discitis. Then comes the weight loss. You ask the patient either you have a history of weight loss in recent days, if yes, how much you have got lost, and in what duration, because it will signify. Because weight loss is associated with backache in cases of any malignancies or a tuberculosis, like infection like tuberculosis. Then you will ask about the previous history of spinal surgery or spinal anesthesia, because sometimes patients present with many types of backache, and it leads to an investigate, leads to the surgery. So you will have to personally ask that you have any back surgery or back problem surgery. The patient will tell you yes or no. So if it comes with the surgery, yes, and backache patient presented with backache with a previous history of surgery, it means that he comes with failed back syndrome. It means the previous surgery failed and it comes again with the same problem. Okay. Then you will have to ask about how the pain improves or it aggravates. Any movement that aggravates or improves. Mostly the spinal जो problems होते हैं aggravates करते हैं movements के साथ. जो mechanical problems होते हैं वो aggravates करते हैं. Movement होती है aggravate होती है. Mostly non-mechanical problems जो होते हैं continuous pain के साथ होते हैं वो stop नहीं होते. For example, if we talk about spinal canal stenosis, patient complaining with the backache, when he walks a certain distance, he feels pain. And when he tried to take a rest and lean forward, the pain improves. This is the characteristic of the spinal canal stenosis. So you have to ask about the aggravating or relieving factor. Either a medication will release the pain or not. It will lead to give you some idea about the severity of the disease. So next one is the previous medications or allergies. Sometimes patient had a previous history of tuberculosis. You have to consider. These are some important key points you have to ask when you are dealing with back pain patients. And you have to remember these things. These are the basic things in history of a back patient with a backache or a spinal problem. So as I talked earlier about the red flags. So these are the red flags. When you consider in your history these answers, you should have some red flags, red lights, that it means something is going very, very fishy. And we have to investigate further. We have to make things more in depth, and we have to patient need an urgent care. As I told you that mostly more than 80%, 90% patients backache resolve without any surgical or a medical intervention. But when you come to the red flags, it means that it needs serious medical attention. So In history of the cancer, for example, as I told you earlier, in unexplained weight loss, resting pain, and age more than 50 years of age, you should consider that there is something problem, backache associated with some other problems, some uncommon problem. You have to have investigated. Then unexplained fever, recent bacterial infection, immunosuppression, patient on immunosuppression drugs, patient having a history of UTI, urinary tract instrumentation. When you ask these things and patient told you the history of these things, that it comes to you that yes, okay, it means there is some osteomyelitis or a discitis involvement, and sometimes abscesses can collect and you have to drain it for surgical intervention if needed. Okay. Then comes the fractures, history of trauma, deformity of the spine in young patient or an old patient, like kyphosis. It leads to gives you some idea about the anatomy of the spine. Means there is some problem and there is some fracture. So non-traumatic cause of this fracture is osteoporosis, and the most common is the lumbosacral one, and it comes with a collapsed vertebra. So the steroids, use of steroids in old age patient and age greater than 70 years old, you can consider osteoporotic fractures of the spine in your differential diagnosis. And then come some rare disorders like quad-equina syndrome, in which the history gives you the idea. The urinary patient with having a urinary retention or incontinence, saddle anesthesia, decreased rectal tone or bilateral lower extremity weakness or numbness, as I told you earlier. This gives you an idea about the condition that we are dealing with the problem having a quad-equina syndrome. Then comes patient with severe progressive focal neurological deficit. Then and any problem of the backache, which after dealing medications or physiotherapy or other conservative management, and it is not improving, a patient is still complaining of the pain and aggravating pain and the aggravating conditions. So it means that the patient is having some other problems, and we need to further rectify the problem, or we have to further evaluate the patient accordingly. So these are the causes, and I told you the pain more than 4 weeks. These are the red flags. You consider it in your history, and when you consider it, you will find the solution. It comes to the general physical examination or a clinical examination. When we are talking about the patient with the back problem, we will take a history and we will examine the patient. So history and examination is plays a pivotal role in the management of a back pain patient. He will ask about the general physical problems, including anemia and the weight loss, and general physique of the patient, general attitude of the patient. Then you will check the gait of the patient, that is how the patient walks. Then comes the spinal examination. And spinal examination, you will examine the spine in either standing, sitting posture, or lie down. So we will have to examine the patient from the front, from the side, and from the back. It will give you idea about the alignment of the spine. The alignment is out, you will have a different types of deformities of the spine. Then you will have also some other markers. For example, you can see the abnormal hair growth, which may indicate underlying bony abnormalities such as spina bifida. Then the bruises that you suggest you recent trauma itself for a surgery, and a scar over the back. So you have to see all these things, and you have to see the muscle wasting. the spinal muscles wasting or spasm, you can observe. Then you will check the iliac crest alignment, the posterior iliac crest, either it is on the same level or it is on different level. It will give you that either you will dealing with the shortening of the lower limb that leads to the imbalance of the iliac crest alignment. Okay, these are some common things. This is the normal one. You can see the normal curvature of the spine. Then this is the lordosis. Then lordosis means excessive curvature of the lower spine. Normal lordotic curvature is increased, then it is lordosis. Mostly the thoracic spine is kyphotic, and you can see normal thoracic spine is slight kyphotic and lordotic in the lumbar region. And if it is exaggerated in the lumbar region, then it is called lordosis. And if it is exaggerated overall, then it's called kyphosis. And if it is both, it is just like there is no any kyphotic or a lordotic, it means it is a flat back. And when it is both exaggerated, either as kyphosis increases and lordosis is increases, it means it is called swayback. And if it is this is alignment from the back side, you can see that not only the spine is vertically aligned in these cases, but there is some transition over the lateral aspect, the lateral bending, lateral deformity of the spine. You can see that this type of, just like an S-shaped deformity, means that it is, you are dealing with the scoliosis. So these are the scoliotic spine. And these are or alignment problems can lead to backache due to different causes. You can identify and you can, this is the lordosis, this is the kyphosis, this one is the kyphosis, this one is the scoliosis. Most commonly you will deal with this. So then after inspection comes the palpation. You can feel. The orthopedic examination based on three things: look, feel, and move. And we have seen the look. Then we are coming on the feel. Feel means then you have to palpate the spinal processes, sacroiliac joint, and alignment, and note the tenderness where you find the tenderness. Now comes the paraspinal muscles. Note the tenderness over the paraspinal muscles, either it is they are in the spasm or not. This is how you can palpate. These are the palpation. These are the paraspinal area. These are the paraspinal muscles. You can palpate these things. And these are the spinal element. You can palpate the spinal processes. You can check the alignment, irregularities, and the tenderness. Then the move. In the move, you will actively or passively move the patient, either forward bending or a backward bending or a lateral bending. This one is the lateral bending. This one is the forward bending. This one is the posterior bending, backward. So you will check the different types of movements of the spine, and you will check how the spine shows the movements, either it is restricted or not, the movements are painful or not. You will have to measure these movements. So you have to do the three types of movement: forward bending, lateral bending, and the backward or posterior bending. Then after doing that, then you will have to perform some special tests to identify some special problems. For example, Scober's test, that is used to identify restricted flexion of the lumbar spine, which may occur in conditions like ankylosing spondylitis. For example, you have mark over here and over here. This is called the dimple of the venous. Mark over here, and 15 centimeter above. Then you ask the patient to just go bending. And if the spine does not do the excursion till 20 or 21, it means the spine excursion is decreased. And you consider that we are dealing with the patient with ankylosing spondylitis. So this is the simple test. Then comes the sciatic stretch test, or it's called straight leg raising test. You just lie there on the patient and raise the leg. If after 30 degrees, it gets painful, you can see the patient is complaining of pain radiating from the leg to the back. It means the SLR is positive, and SLR also shows the range, because start the pain from where to where. You have to mention it. This is called a sciatic nerve irritation or sciatic nerve stretch test. And it will give you the suggestion of the sciatica. The other one is the femoral stretch test. You have to prone the patient. You have to lift the knee up and the leg up. And you will this maneuver helps you to stretch the femoral nerve. So you actually irritating different types of nerve roots. For example, femoral nerves have a different nerve root and the sciatic nerves have a different nerve root. So when you will do these stretching maneuvers, you will actually come to know exactly which nerve root is involved. So these are the common tests. There are so many as well, but we are not discuss in detail the other. Some causes of the backache: 80% of the back pain is caused by weak or tense muscles. Majority of the low back pain actually originates in the sacral ligaments. 50% or more the facet joint at the site of dysfunction, and 90 and 95% back pain is due to discs. An extremely high percentage have physical problems. 50 to 70% of the chronic symptoms are psychological in origin, and that is very important thing to consider, that in chronic backache mostly there is a element of psychological problems. So when dealing with chronic backache, you have addressed the psychological problem of the patient as well. So according to the anatomic sources, that is important. You should know that which structures give you which type of pain and what are the possible sources of the pain. For example, we will talk about disc. Disc give you pain of the discitis or disc prolapse. Then comes this facet joints. The facet joint give you pain of the osteoarthritis or a far pars fracture. Then comes with the sacroiliac joint that will give you pain if they are involving in arthritis, ankylosing spondylitis, or in cases of tuberculosis. Then the ligament, for example, the common ligaments are the ligamentum fleon, and when it hypertrophy, it gives you symptoms. Then pain can come from the muscle spasm of the back, maybe sprain or spasm that gives you backache, and which is among the most common causes usually. Then cord, and cord can present with the primary tumor or a secondary tumor, and it comes with severe pain and other symptoms as well. Then comes the infection and the cyst of the around the spinal region or spinal cord. Then comes the nerve root or nerves, the spinal nerves. And then when it compresses, it may lead to the pain, give you a backache. So either an irritation or a compression, or due to any reason, the cause of the backache could be nerves. So we have to identify from which anatomical area the back pain is arising. Either it is arising from the disc or the bony region of the spine, like facet joints, or a sacroiliac joint, or a ligament segment of the spine, or a muscle segment of the spine, or a soft tissue like the nerves or a spinal cord. We have to differentiate it and we have to identify. For example, this one is the discitis, this inflammation of the disc. If the pain arises from this region, it's called discitis. Mostly it comes with infection of the vertebral bodies, and you will patient will consider with fever and low back pain, which is usually continuous and aggravates with movements. Then comes, I told you, the ligaments. The common ligament with this one is the posterior ligament. It's called ligamentum flavum. The other one ligament is like this, anterior spinal ligament. Over here, this is the spinal cord, the spinal nerves, and this one is the ligamentum flavum. And when it is hypertrophy or it becomes thick, then it leads to the compression of these nerves. That it gives you the pain of nerve compression or cord compression. Then how we identify? Usually identify on MRI. As I told you about the bony involvement, bony problem. So these are the facet joints. These are the joints of the spine. One is this joint between both discs, and this one is the facet joint. So you can see that this is when thin, it leads to increased pressure over these joints, these facet joints. And these facet joints, when feel more pressure, then they become degenerated. And these degenerated leads to pain for the back. These facet joint pain do not radiate. They are usually localized. This is the characteristics, and more oftenly the differentiating, how you can differentiate an examination, you ask the patient to fall back and the pain aggravates. The disc pain don't aggravate like this. Mostly the facet joint, because after giving you back pressure, you can increase the pressure over the arthritic facet joint and leads to the more pain. So these are the common arthritic pain in the spine if you are dealing with the arthritis. And you can identify these things on the CT scan or MRI. Then comes with the ankylosing spondylitis. As I told you, this is the inflammatory arthritic condition, and it's a systematic involvement like rheumatoid arthritis. You can see that these are the anterior osteophytes, and you can see the spinous fusing. These are the inflammation in the vertebral end plates, and you can see that these fuse, anterior element are fusing, and you can see limited movement, just like it acts like a bamboo spine, just like a bamboo spine. So you cannot find any motion over these area. And as I told you earlier about the Scobber's test, you cannot find any spinal excursion. As I told you, any excursion of more than 5 centimeters is needed. And if it is not, it means that you are dealing with any problem of the spine with having a restricted spinal excursion. And the most common one is the ankylosing spondylitis. So the risk factors associated with back pain are the congenital spinal abnormalities, smoking, occupation, as I told earlier. Some occupation leads to more backache, prior episode of the lower backache, and physical unfitness and increasing age. These are the common risk factors which are associated with back pain. As I told you earlier, the non-specific causes of backache are abdominal aortic aneurysm, nephrolithiasis, pancreatitis, arthritis, and pelvic inflammatory diseases. Most spinal cause of the low back pain will be aggravated by spinal movement. This is important thing, as I told you earlier, that if it is arises from the spinal element, it will aggravate with movement, and it will relieve when you will lie down or you will not do any movement. But in non-specific cases, the pain does not have any relation with the movement of the spine. So these are the differentiating factors. That is continuous, and either you move or rest, the pain does not have any relieving factors. But in cases of a spinal element, pain will aggravate or decrease with the movement. As I told you about the cauda equina, the large central disc herniation, this is the cauda equina. These are the conus medullaris, the term the conus medullaris, where the spinal cord ends at the level of L1, then comes the spinal nerves. Spinal nerves comes from above and goes below, just like a horse tail. When these spinal nerves or the bunch of spinal nerves then compress anywhere in this region, it's called, leads to the term cauda equina. This is not a cord compression. This is called spinal roots compression. So retention, usually how it presents, the patient presents with urinary retention, or which leads to the overflow incontinence later. Normal post-white residual essentially rules it out, and so there's a surgical emergency. It needs to be surgically managed. Otherwise, it leads to the permanent damage. So, if you have a normal post-white urine, residual urine, it means this is not a cauda equina. So, you have to consider it. Then I told you earlier that the compression fracture, especially in osteoporosis patient, in most common location is local lumbar region or a mid-thoracic region. The pain may not be localized to the level of the fracture. It's not necessary to localize over this region. Fracture may present with low back or lumbosacral pain. The whole region can be involved. And these are the common cause of the senile osteoporotic lumbar back pain. Lumbar spinal canal stenosis. I'm talking you the common condition according to different ages which leads to the back pain. One is the old age compression fractures, some rare causes like cauda equina, and lumbar canal stenosis. Congenital onset is in 30s में, degenerative में most common है, or mostly they are at late 50s or 60s or above. The most common nerve roots involved are L4, L5 region followed by L3, L4. Mechanical compression leads to the compression of the microvasculature and nerve root ischemia. Increased microvascular permeability and edema. This leads to the nerve root involvement. These are you can see these are the disc prolapse. You can see this one is, and you can see this one is the nerves coming down, and you can see how much this compressed, almost more than 50-60% compression. This is called spinal canal stenosis or narrowing. And I talked to you earlier that the efficienting point is that there's more pain when you're standing, and this is less pain when you lean forward. Why it is? Why it is? Because when you lean forward, your spinal canal diameter increases. So then, if the spinal canal diameter increases, so the pressure over the nerve roots will decrease. That is the important thing. And you can see patient will tell you that I am feeling more comfortable in lying forward, leaning forward rather than more standing. So this is the characteristic feature of the spinal canal stenosis. Onset is usually insidious, chronic low back pain that progresses to the buttock or the thigh and the leg. It can radiate anywhere. Depend upon the nerve root involved. Patient presented with fatigue, heaviness, or pain in the legs with ambulation. This is called neurologic claudication. See what is neurologic claudication? Patient walks with some distance and starts paining. This is called neurologic distance. And what is vascular claudication? If the cause is vascular, then it is called vascular claudication. If the cause is nerves, then it is called neurologic claudication. So we have to measure the claudication distance. How long you walk, how far you walk, and then you consider that the pain is now starting. You have to measure the distance. Either the distance increased or decreased, or it remains constant. Then you will have to relieve. Pain is relieved on rest or stooping forward. These are the things that I have told you earlier, that this is the characteristic of the spinal canal stenosis. So most common findings are loss of lumbar lordosis, limited extension, trunk is flexed forward, standing. This is called Simon posture. And no significant tenderness on palpation, negative straight leg raising test. Normal SLR is negative when it is in pain. When we will raise the leg to more than 45 degrees and it is painless, it means it is negative. And if pain occurs from the 30 degree up to 70 degree, it means that SLR is positive. This is called sciatic nerve stretch test, as I told you earlier. Then the normal motor exam despite the report of the disease. Then the lumbar radiculopathy. The most common cause is the prolapse, disc prolapse, and we are dealing 90% of the cases of these disc problems. Mostly the L4, L5, and the L5, S1 discs. Mostly the mechanical compression, pain with sitting, bending, and coughing, and pain radiates below the knee in a narrow bend. You can see this the disc, how the disc behaves. This is called the disc bulge. It's like this. If this diameter increases with this, it's called disc protrusion. And if this diameter increases, then this is called disc excursion. This is all you can see with the MRI, as I told you earlier. And if this is separate and this one is separate, this is called sequestration. In the previous MRI, I told you, yeah, this one, you have to check this diameter. This one. This is disc protrusion. 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 Listing away from the side of the disc herniation is called paracentral herniation. Straight leg raise, SLR for L5, S1, reproduction of the radicular plane below 30 to 70 degrees. As I told you, if the pain occurs, it means the SLR is positive. Highly sensitive but low specific of the disc. Then you will do the crossed SLR, and it's more specific but less sensitive. You can do this, both of this. So, how you can differentiate the radicular versus deferred pain? Radicular pain, leg pain in the leg more than in the back. When it's somatic deferred pain, the pain in the back is more than in the leg. In radicular pain, it is usually like a shooting or lancetting type and having a proteinous component. But in cases of somatic pain, which is mostly dull, pressure-like or deep, the radicular pain travels along the limb in the narrow band, while it in somatic referred pain, it extends into limb across a wide region. In radicular pain, there may be or may not be any neurological deficit. In somatic referred pain, there is usually no neurological deficit. So we can differentiate these terms according to the history and the patient gives. We will ask these components in our history, and we can differentiate whether it is a radicular pain or it is a radicular pain. Then comes with the investigation. We have dealt with the till now we have dealt with the definition, the classification, the common causes, the history and examination, and now we are here with investigation. So not every backache patient needs investigation. As I told you earlier, that more than 70-80% cases, they don't need any investigations. They need only reassurance and some lifestyle modifications, and the back will be resolved. But sometimes, if the backache occurs, as I told you earlier, that these are the red flags, and you will have to investigate. For example, in labs, you will do the CBC, you will check the TLC count. If it is raised, it means some infective element is involved. And you will do the CRP, which is raised usually in infection. And you will come with the ESR. If it is raised, for example, the ESR normal is less than 10. But if it is more than 40 and less than 50, it means then you are dealing with some inflammatory disorders like ankylosing spondylitis or rheumatoid arthritis. But if the ESR is more than 70, 80, more than 100, it means you are dealing with the problem with either infection or malignancy. So the ESR tells you that where your diagnosis is leading to. So as I told you, some non-specific causes like UTI, you have to rule out this. You will ask for the burning maturation, and the patient told you that, yes, I am having, you will go for a urine differential or a culture insensitivity. And if you consider your Cobber's test is positive, then you will go for a HLA-B27, which is a specific for the ankylosing spondylitis. And if in cases of old age patient with backache and vertebral collapse, and you will consider multiple myeloma as a tumor of the bone or spine as a differential, and you will go for a serum protein electrophoresis. There are so many other tests specific for different things, but these are the common, as I told you, that these considered in different common conditions of the back. So not every back pain patient needs to be investigated with radiographs, but some need it. When we consider it that we need it, you will go for a proper views of the radiogram. You should know what are the dorsolumbar means the thoracic and the lumbar spine, and the lumbosacral means lumbar or sacral spine, both anterior, posterior, lateral, oblique, and bending views. These are the views of the spine which is needed when you consider for a patient with a spinal problem. And if you consider that the problem is a bony region, either a tumor or a trauma, then you will go for a 3D scan or CT scan, and you can identify these lesions on the CT scan. So you should have to consider, and you should know what are the problems and when to do which type of investigation. So the MRI leads to soft tissue tumor, disc prolapse, nerve impingement infection, and TIM99 bone scan help you inflammation, infection, and tumor. These are the lateral bending radiographs. These are the AP radiographs, and these are the lateral. You can see that. So you have to consider these X-rays when dealing with the problem. You can see these are the deformed spine, and you can check when they're doing the lateral bending views. The problem aggravated, not better. It means that the deformity is more or less static. If it improves, the deformity improves with the lateral bending views, it means this deformity is a dynamic one. This deformity, this is called scoliosis, is a fixed deformity over here. So you have to check. So the bending views tell you this story. These are the normal views. You will check the alignment of the spine. Not only this, you will check the sacroiliac joint. You will check the osteophytes. You will check the the bone levels, that either it is equally spaced or disc problem. You can check the osteophyte. These are the osteophytes of the spine. You can check the spinal canal. See, this shows the height of the discs. This gives you an idea, and this gives you some sort that this is some sort of a compression fracture over here. So these are the different things you can consider while checking the radiographs of the spine. So what are the different treatment strategies of the back pain? As I told you earlier, that the most of the backache or back pain will resolve spontaneously. It's doing some mild measures. Don't need any investigations or a medical therapy or a surgical intervention, unless and until you will come across a patient with a red flag. So what are the treatment strategies of the back pain? These are some conservative and non-conservative. Conservative management will be the lifestyle changes, like some increased dietary changes, like you have to decrease your weight or take diet with high calcium component, exercise, or cutting of the smoking. These are the important lifestyle changes you have to do. You will check your mattress where you lie down. You will check your chairs where you sit. You will check your posture, how you sit, how you lie down. So these are the changes you have to check, because these are the common cause of the mechanical backache. Then comes the physical therapy. It has an enormous role in the management of the backache, because most of the problems, the mechanical backache resolves with physical therapy without medications. And some need medications. Some need spinal injections, some need surgeries. So these are the treatment ladder. For the patient who do not improve with self-care options, consider use of non-pharmacological therapies with proven benefits, like physiotherapy. A number of therapies appear similarly effective. Emphasis should be given on active rather than passive therapies. Exercise therapies, cognitive behavioral therapies are the first line treatment. Focus on the function and not just on pain. You have to address maladaptive coping behaviors such as fear avoidance. Interdisciplinary rehab for patients with severe functional impairment or strong psychological component is needed. That is very important. You have to consider, as I told you, a patient with chronic backache have some psychological element as well. It may come you with depression. So backache with depression has a very vital relation. So chronic backache, the patient comes, most of the patient comes with depressive element. So you have to address this as well. So the other one is the manipulation, acupuncture, massage, and adjunctive therapy. These are, for example, adjunctive therapies, including spinal fractions. So this will help in relieving the mechanical back pain. And it will adjunct with medications. And consider medications in conjunction with back care information and self-care. Most patients need NSAIDs, and these NSAIDs are the first line medical options. The other one is the second line, including muscle relaxation, skeletal muscle relaxation, especially in acute cases, some antidepressants in chronic cases, and anti-seizure medications in chronic cases. Mostly you have to avoid the benzodiazepines, especially in the acute one, because here the skeletal muscle relaxant and the NSAID will work better than the benzodiazepines. And steroids are usually not recommended in cases of treating a backache, either acute or chronic. So, in summary, the rates of the lower back pain and associated costs are increasing despite more aggressive testing and treatment. Use evidence-based principles to inform more effective and efficient care. जरूरी नहीं है कि आप हर पेशेंट को इन्वेस्टिगेट करें, हर पेशेंट को आप ड्रग्स दें. You have to do an evidence-based test. अगर required है तो करें, otherwise mostly patient will benefit from conservative management of lifestyle modification. Shift away from routine imaging and diagnostic testing. Early identification and management of psychological contributors to the pain should be considered in cases of the chronic disease. Focus on function and not just on pain. That is very important. खाली pain relief नहीं करना, उसका function, उसकी functionality भी देखनी. Set an achievable functional goals. Self-care and education to all patients is very priority. Focus on use of active non-pharmacological therapies, passive therapies, adjuvant role, caution use of opioids, and usually non-invasive approaches to the mostly lower back pain is the task of the day. Consider non-invasive procedure rather than invasive one, including medication, and mostly by doing lifestyle modification or some physical therapy, relieve the back problem. Consider first that where the problem is arising from the spinal element or some other viscera. If you can consider that it is a spinal element, then consider it is a mechanical problem or a non-mechanical problem. And it is a mechanical mild, then go for lifestyle modification or physical therapy. If it is moderate or severe or you need an emergency, you can need a surgical intervention is needed. In cases of the other rare causes like tumor or infection, deal accordingly after proper and detailed investigation with relevant history and examination. So I think we will end our lecture over here and we will move for some relevant question and answer section. If anyone have any question, he and she can ask. मतलब कोई क्वेश्चन आंसर तो नहीं कर रहा है ना? Full form. ये जवाब दे रहा हूँ. वाइस दे रहे हैं, वाइस दे रहे हैं. आपसे पढ़ रहे हैं. हाँ यार, पहला सवाल है ना, यहाँ पे करना. चलो. जिसने कहा स्लाइड किया गया है, कैन यू सी द फर्स्ट टाइम, यू कैन सी हाफ ऑफ द स्लाइड। ये कैसे हो सकता है, हाफ नहीं देख रहा, हाफ नहीं, mistakes the slide, we can't see half of the slide। ये तो मैं मुझे लगा होगा बाकी और फिर स्लाइड तो मैं कह रहा हूँ तो पूरी आ रही है, स्लाइड पूरी आ रही है। भाई वो वही जवाब दे दीजिए, ये तो दिए मैंने। ओके, थैंक यू वेरी मच। इसको बंद करते हैं, स्टॉप शेयरिंग, पार्टिसिपेंट तो है अभी तक बैठे हैं, तो ऐसा ऐसा रहेंगे। अच्छा अच्छा, वो आपस में डिस्कस कर रहे थे ना। हमें भी जब चलना चाहिए, ऐसा तो क्वेश्चन नहीं है, नहीं लेकिन तो कर रहे हैं, कोई और नहीं आ रहा, नहीं आ रहा, वो टाइमिंग के साथ से वहाँ स्टूडेंट तो बंद हो गया, लेकिन शो करेंगे क्वेश्चन और तो नहीं लगे, क्वेश्चन तो नहीं लगे, चैट तो मैंने देखी नहीं, और तो नहीं चैट